uni, I, like many people, was taught what to ask, right? They teach you how to take a subjective, what makes it worse, what makes it better. There wasn't even the Peter O'Sullivan's line of tell me your story at that point. It was just, how can we help? What's brought you here? What happened, so to speak. Going, learning what to ask, essentially. And you could have your template on your piece of paper at the time. This was before computer notes. And you just ask, and that was it. And that, I'll be honest with you, Mark, that was it for comms training. There was nothing about difficult conversations.
Welcome back to the podcast. Today, we're diving deep into a topic that's at the heart of effective healthcare: communication. How do we move beyond traditional authoritative interactions to truly collaborate with our patients? Our special guest, Ben Whybrow, joins us to explore the power of guided discovery, a communication style that fosters a shared understanding and empowers patients in their own healing journey. Ben, who has recently joined the Modern Pain Care team, brings a wealth of experience as a pain specialist physio and host of the Clinical Communication podcast. We'll be discussing how to shift from a paternalistic approach to one that recognizes the patient as an expert in their own life and experiences. Want to put these principles into practice? We've got you covered. Head over to our show notes to download our exclusive Guided Discovery Clinical Companion. It's packed with ideas, STEM questions, and dialogues to help you hone your skills. Now, let's get into the conversation with Ben Whybrow.
This is the Modern Pain Podcast with Mark Cardula.
Ben, welcome to the podcast.
Thank you, Mark. Thank you for having me. I'm looking forward to this.
Yeah, it's good to have you, man. I'm excited, and I'm also excited because Ben has joined the Modern Pain Care team. I've noticed Ben online, and he talks and speaks in the same ways as far as, and has a definite similar thinking process. So that's what drew me to Ben's work. He's got his own fledgling podcast that he's recognized as well as I have, that it's more work than probably we'd like him to be. But Ben's joined because he's going to act as our community manager in a community course that we're soon to release here in the next month or two. That's going to hopefully deliver some significant value of helping people really hone a pain practice in their own practice, be it with individuals or be it with groups, and really have a structure and a framework to go off of that you can immediately start making impact in your community. We'll talk about more on that as time passes on, but if you're interested, definitely check out the show notes. We'll have some ways you can sign up if you want to keep abreast of those developments and when things are released. With that said, Ben, your second time appearance here on the podcast, but if you can just kind of give people an update where you're at, what you're up to.
Sure. Actually, things have changed a bit since we last spoke. So yeah, I still clinically work as a physio here in the UK for our wonderful NHS as we call a pain specialist physio. I'm doing this in air quotes that people might not see. Seeing people like you, Mark, who have got persistent pain, whether it's in one place or all over their body, and trying to support them. As part of our MDT team, we have consultants, nurses, OTs, psychologists, and a bit more. And we, like you were just saying about groups, yes, we see them individually. We have our own pain management programs as well, where we support them in groups, not just individually. Also, as you kindly mentioned for me, Mark, there, about a year ago, just under now, I started my own podcast. You're grateful for mentioning that, called Clinical Communication, to help spread the word and improve the comm skills, not just for physios, healthcare in general. It's obviously most of the listeners are physios or physical therapists at the moment, because I know about 40% of my listeners are American, apparently. But it's coming along, 42 episodes now. But as you rightly said there, Mark, it is a lot more work. Like parenting, it's a lot more involved than you ever imagine. So yes, I've learned a lot over the past year, and still doing a bit of teaching as well. Still work at the clinical school, teaching that kind of stuff. But that's where I'm up to now. And also obviously going to be helping you with this program.
We're excited. I'm in the throes of finishing the final touches on it. I've been fortunate to work with Bronnie Thompson. She's been a big support and advisor in developing this. And then you're coming on board with, again, clinical communications. That's what a big part of the program's about. So it's a great fit, and we're excited to launch it, especially taking a course beyond what we've normally had, where it's just, here's your recordings, listen to them, and then maybe do an exam at the end. This is going to be much more an active learning process where you're applying it, basically designing a course that I wish I had when I was trying to learn how to deliver this stuff. But one of the things we're going to actually talk about in the course that we figured might not be a bad idea to talk about today is communication again, but more specifically a different communication style. Because I think as we come out of school, we're very much wired into more of a, I guess, an authoritative kind of, people call it paternalistic, where there's this expert and there's this novice in the room, and you're really dispatching your knowledge upon the novice to educate. And don't get me wrong, there might be a time and a place for that style of communication when it's invited and when the context is correct. We'll talk about maybe what that context is instead of I think maybe traditionally that was the context. That was just the nature of the interaction. It was very much prescriptive information coming from the expert to the person who doesn't have that expertise. So the whole point of kind of guided discovery is sharing the expertise in room. And if you've listened to the podcast, we spoke to shared expertise, the third space, things like Cohn and Quintner coined in their writings, but also just looking at the patient as an expert in their life and all the context that we know if we're looking from a complex biopsychosocial model that they bring to it, that we need that expertise is stuff we need to know about to help them hopefully connect the dots in a very complex experience. I'd love to hear from you, Ben, just how you were maybe taught communication in school, how it was portrayed to you and how you conceptualized it coming out of school. And then as you saw patients and saw how folks are working with people with persistent pain and maybe some of the complex biopsychosocial factors we see emerging in interactions, how that may have kind of grown or what's developed as time has passed.
So uni, I, like many people, was taught what to ask, right? They teach you how to take a subjective, what makes it worse, what makes it better. There wasn't even the Peter O'Sullivan's line of tell me your story at that point. It was just, how can we help? What's brought you here? What happened, so to speak? Going, learning what to ask, essentially. And you could have your template on your piece of paper at the time. This was before computer notes. And you just ask, and that was it. And that, I'll be honest with you, Mark, that was it for comms training. There was nothing about difficult conversations. There was nothing about behavior change, motivation interviewing, ACT, all that stuff. Nothing. And obviously at the time, when you're at university, you just assume that's what you should do. And I'll be honest with you, my placement, how it was, that kind of came across as well. It was still quite biomedical. All of the biopsychosocial stuff we talk about was still quite, it was known, but it wasn't talked about a lot. Everything was still very structure, pathology, resolve it. However, I left uni, and I always credit my father-in-law a bit for this because he recommended the book How to Win Friends and Influence People. You ever read it?
I have. Great book.
Great book. So I read that at 21, the gap between leaving uni and then starting work. And my father-in-law, I'll be honest, he's the epitome of that book. Okay, he's got a bit of charisma, a bit of charm, a bit of knowing the right words, how to be at the right time. And that experience, along with, I will say, one of the last educator I had, who also, I didn't realize it at the time of being on the placement, but after reading the book and some other experience, realized he epitomized that too, because he had a certain, whether it was relationship, rapport, way of being with patients that just got trust, got, I say buy-in, a feeling of care, feeling of support. Just immediately they felt they were with someone who could help them, even though he hadn't done anything at that point. He was just saying hello, asking them some questions, but his presence, if we call it that, made it feel that way. When I had those experiences, which were good and helped open my eyes a bit, but this was over, we're talking 11 years ago now, so still quite biomedical, still quite structural focused. I read Louis Gifford's Aches and Pains books about a couple of years into working. And I'll be honest, that was the thing that really opened my eyes to all this. Those are the books that I recommend to any, not even physical therapist or physio, just anyone who's working in a musculoskeletal field. You will get more from those 3 books than anything else that's out there. You read them at all, Mark?
Oh yeah, huge proponent of those books for sure.
And incredibly well written. And even though they are, I would say 10 years old now, they are as relevant today as they were then. And like I say, so easy to read. It's not a big textbook which puts you to sleep. They're really good reads. And like I said, that was really what got me to focus on. Actually, it's not just the structural bit, it's everything else that's going on with it. And over time, reading other things, speaking to people like yourself, many other experts, and just having the patient mileage and my own interest in it. And that's what grew my interest. And I think over time, at least for my social media bubble, it appears that we're changing. We can't say the same thing for the whole profession or the whole of healthcare, but I feel that it's slowly realizing the greater importance of not just communication and getting it right, but also the biopsychosocial nature of people's health as well.
All those books, and I will definitely link them in the show notes for those of you who want to read them, because they are definitely worth investing some time in. The Gifford books sounded like he was rehashing a bit of my career with some of the mentoring issues and stuff where he had like Jeff Maitland mentoring him, which amazing contributor to our profession, but recognize these patients that have some complex pain presentation in his practice. And I saw the same thing in my mentoring. So it was one of those shining light moments when I was down and having maybe an existential crisis in my own career to see that, okay, he went through this and he really had a pretty profound way of putting it in words and in a motivational way to say, hey, there's a lot we can still do. And that definitely drove me to, and it's hard to believe those are 10 years. That is definitely books you must read if you're trying to help somebody who's dealing with some persistent pain issues, especially when you're tussling with maybe how we were taught and the shortcomings that we're seeing when we're putting on that clinical mileage, as you put, and maybe seeing that it's not really bearing fruit with some patients. I think it can really open your eyes to helping maybe connect with those patients. So let's discuss a little bit about the guided discovery approach too, because Gifford's way of talking about communication stuff just meshes well within this, where it's this collaborative stance you're taking with a patient, and it's this Socratic questioning where you're having the patient, you're almost sequencing questions that they're very open-ended, where the patient can notice thoughts, test their assumptions, and reevaluate their assumptions and it really also fits well with behavioral experiments and exposure-based where you're really guiding the patient to say, what do you notice with that? And you tell me your pain's constant. Can you talk with it? Are there any times where it's not, or where instead of these open or these shut, closed-ended questions, which sometimes what to ask at uni is sometimes what those questions were. What's your number on a 0 to 10 scale? Yeah. I'm wondering how you see the collaborative stance of guided discovery questioning and how you aim to have that kind of stance within a discussion with somebody versus maybe that more leaded or more directed, authoritative, paternalistic communication style.
I think you alluded to it, just what you were saying there about the open-natured Socratic style of the questioning, what or how, essentially. Questions that start like that, you can't end with just one word. There has to be a bigger answer to it. And there's a lot of things that has already been said that helps us with this. I mentioned earlier about Pete O'Sullivan says about, tell me your story. Now, that's when you ask that question, they're going to give you their version of their story, okay, what they've taken away. You may have in your notes or things you've read that actually something else has happened that they either haven't said or is different to what they've told you. So that open questioning, that finding out from them what they've grasped, really gives you an insight into them and where you need to guide them. Now, there's no guarantee, of course, that when we're doing guided discovery, they're going to end up at the location we want them to end at. It may go a different way because they may interpret things differently to how we perceive them, whether it's past experience, whether it's things that's been said either from us or from other people. But the power of, as you rightly said, those open questions, especially questions that ask about feelings, I think as well. When this happened, how did that feel? How did you feel when you were able to bend down and pick up that pen which you were fearful to do in the past? What do you feel like when you can't put on your shoes as easily as you could previously? Feelings are very powerful because it's more than just an output, if you will. It's more than just a function. It's the emotions. It's these other psychosocial bits that we want to harness, want to get an idea about, that add into it. So I think that's key, to be honest. The first thing is open questions. I'd say you have to be careful. You can't always ask every question open. Sometimes you have to be closed, and that sometimes helps you get to the point a bit quicker. But I completely agree with you. That style of questioning really helps us first understand where someone's at, and then also then helps us try and guide this discovery you're talking about, where we want them to experience.
Yeah, I think there's such nuance to every conversation we have. So there's not really a guide or a guidebook, although we're going to give you the opportunity if you want to download a guidebook that we'll have listed. That just gives you some ideas, some STEM questions you can ask, gets into the how to ask, what it might sound like. We'll give you some different dialogues that you can get and some common issues we have where we want to slip back into advice giving and go into maybe our old traditional ways, maybe digging into some discussions with that. One thing that I've found helpful is what's showing up. And as far as when you're asking yourself to bend and do something to tie your shoes, what's showing that? And obviously a lot of people are going to default to, I feel tightness in my back, or I get this pinch in my hip, or whatever it may be. And those are good things. Okay. Yep. That's understandable. What shows up in your head? I'm just curious. Do you have any, some people might mention they're a little bit fearful or anxious. Do you have anything that shows up in your head when you're doing that? How do you work to get to because you're right, a lot of these questions can get into the depth of the experience where it's not just, what's the lumbopelvic rhythm or things that maybe traditionally we were going to look at. What is the whole context that's showing up for that patient, not just physically and physiologic sensation wise, although that's important. We want to know what kind of sensations are showing up, because then we can teach people skills and things to respond to those sensations in maybe ways that don't ramp things up and move things more in a fruitful direction. But any other strategies you use, Ben, to get to the cognitive feelings, emotions, thought? You mentioned a little bit of earlier, but I'm wondering if you can kind of expand on that a little.
Yeah. So I think the first thing is to say that you can do this in multiple parts. So you've got different points in your assessment where this can come up. And anyone who's a bit, I say, undergraduate or fresh graduate, you will, just because of it all being fairly new or still getting used to it, you will naturally probably go through the questions in order. But as you gain experience, I'm sure you're the same, you learn to bounce around your questions. You can answer them in different ways depending on what they say. I always, first of all, and I think this should be routine, but it isn't in a lot of places, ask, as part, we do our past medical history screening, right? We ask about weight loss, we ask about fractures, we ask about surgeries and all this jazz. But I've yet to see a template that says, how's your mental health? I've yet to see it. And it's very simple. It's one question. Again, it's open, it's Socratic in a way. And it gives you an idea, first of all, not just where they are now, but you could follow it up by asking maybe how it was in the past, if they had any other input. So it gives you an idea of, I guess that's more general than specific for pain, but perhaps how some of those, what psychological elements in this case would be involved. I think also when they're telling you their story about what's going on, we said about feelings earlier, you gave some great examples as well. So if someone says, I went to a consultant who said, I have the back of a 80-year-old. Hopefully they don't say that as much anymore, but you still hear it occasionally. How did you feel after that happened? What were your thoughts about that? What did you think when they said this? What effect has that had on you since? All open, as you heard me there say that, all open questions. You can use it there. You can, as you hopefully ask, if we're being in the social side of things, we're asking about work, we're asking about hobbies and interests, we're asking about who's at home. What effect is this having on your life at home? What about your relationship? What help is your other half providing? Are they having to care for you? We're getting, and like the last one wasn't open, that was closed, but we're getting an idea of not just where it hurts, what makes it worse, what makes it better, but also get an idea of the effect, because you're then going to finish your assessment. And when it comes to then having to do some explanations, having to discuss about what's going on, and Peter O'Sullivan has touched on this in the past, as have others, that when we're trying to, where it's appropriate, explain back, then you use the story, if you will, of what's been told back to them in a way to, and then you can add in some, depending on what they know already, you can add in information about sensitivity and nerves and whatever you feel is relevant. But because we're being personal with it, and because we're using information they've provided, it's more personal to them, it's more relevant, rather than just some generic spiel. As you said, we don't just want to sit there, we don't just want to throw information at the wall and see what sticks. Because I'd also say, I'm just thinking of what you asked as well, when we come to explain it, if we want to avoid being the person taking charge, the person just solving said problem, we want to know what they know, and we want to know what they want to know, potentially. They may know a lot. People that have come to see me, I've probably seen a pain consultant, seen a pain nurse. They may have seen someone else as well. They may have been to some educational stuff. They may have done their own reading because we use AI these days and all that jazz. They may know a heck of a lot. I'll be honest with you, Mark, the days of me giving some long explain pain spiel are long gone. I find now, I don't know if it's the same for you, that the amount I explain about pain has gone down rather than up. Is that the same for you, do you think?
Yeah, no, definitely. I think to me, it was another almost example of us trying to lead, and really, to me, it gives an option. And I think contextually it can have its place. Definitely, it's much less than where I think it was early on, where if you had pain and you were in my presence, you were going to get some form of pain science education. There wasn't a lot of major deciding factors outside of that. But yeah, I think the explaining that stuff, being able to get to the whole breadth of somebody's experience, and you get all these puzzle pieces of, what do you make of that when you can bend in certain situations and bend and it doesn't hurt? Where instead of this is where the effects of a contextual experience show up, and you start getting into this like long-winded, drawn-out thing where I think you can help patients more aptly discover and lead themselves to that maybe it's not true, because then you get into what makes you think that, what's the evidence, where you get the information to think that your back might, I don't know, go out or whatever it may be that the negative things are. But yeah, no, getting back to the neuroscience education, it's much, much more nuanced and I would agree. Rarely, I haven't drawn and gotten deep into the alarm system or done too much of that lately. I do find that there's some benefits of, as we do these kind of discovery processes, really get to the breadth of all the complexity, and we have the patient and I look at, kind of summarize all this using some motivational interviewing that have been going on around this. And then I sometimes will try to just loop in a little bit of discussion, like when the body's in perpetual distress of all these challenging things that I reflect back to the patient you've been going through. Would you be okay to say we discuss a little bit of how that can affect your stress systems, can affect how you experience pain, and then get into a little bit about, it can open some doors, especially if they have overlapping pain conditions where other body systems are showing dysregulation because their life has become a very challenging, distress, anger, emotion-filled, frustration-filled experience, for good reason for some of the experiences people have. But it sometimes can open that door. But outside of that, these days, I don't really get it. I have not explained an ion channel to somebody in ages, although I got really deep into it for a while. So I agree. I think overprescribed as many new interventions are, and they're new and shiny, and our availability bias is present and fully on blast. But where else do you think some of the guided discovery approaches have helped you in practice? There's been some things we spoke about before, and maybe we get into this now, where before we went on, and we talked about how it's easiest for us to explain when somebody tears an ACL, or a relatively concrete explanation, right? There's an imaging finding, there's a concrete diagnosis.
Yeah.
It doesn't take much for us to figure that out, as far as, and the patient to get on the same wavelength with the patient. But then we see patients where there isn't a diagnosis, or many coming from many different people that are often sometimes conflicting in nature. And then the patient, I'll ask, does that make sense to you? Do you feel like any of those diagnoses make sense to you? And they're like, no, they don't. I don't know what's going on. But how do you navigate that difficult discussion? I know maybe a little bit off where we just were. Where do you feel we can make some headway with patients when there isn't? Because this is where I know clinicians definitely have had this discussion with me as well, and folks I've mentored, as far as like, they feel like patients want to have this black and white answer. This is it, and and that's not going to happen with a lot of these cases. Yet I've found if you're very honest and open with a patient, they actually respect that just as much. I'm wondering what your experience is and how you kind of maybe approach that, where there's this ambiguity and uncertainty that exists in the room, but how do you still make a beneficial interaction onto that?
Yeah, I think you're right. I'd say it's actually harder, yes, when you've got multiple different diagnoses being thrown around. That is often harder when nothing is found, in a way, because they're still having to juggle different thoughts, different expectations, different prognoses in the air. There's still, that uncertainty is almost more prominent than if they've been through the battery of tests and whatever else and it came out clear. But at least that bit's done, and then hopefully, and then you can move on to the accepting and managing and moving forwards bit. If there's still different diagnoses, I will first often, I'll be honest with you, unless it is barn door obvious, which in those situations it probably isn't, then I'm not going to go and add another diagnosis into that and try and confuse the matter even further. I would say that if you've got someone who's going through the journey at the moment of different diagnosis, different clinicians trying different tests and different procedures and blah, 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 let it roll, let the process go on, because a lot of this comes down to timing. Sometimes someone has to be ready, not just acceptance ready, but also ready that the diagnosis, or whether it does get labelled or nothing. Now, is there ever truly nothing? Then we do have terms for these situations like fibromyalgia or the general chronic widespread pain now and chronic fatigue and stuff like that. But let it be the right time, because I think timing is something that we just don't think about. We think about, obviously, the structural bit of it. We think about words that we say. We think about a bit more about how to say them in our tone. But it needs to be the right time for this person. I'd say if someone's coming in, like I said, if they've got multiple diagnoses, multiple procedures going on, let that all roll. But find out from them, how can I help you at this time? What help would you like from me? The classic question of what do you want to expect from us? What matters to you at the moment? Because if we're being, I'm going to be a bit act here, but if we're being values driven, right, we're working towards what's important to them, even while all these other things are up in the air. And you may then just have to move along with it, wait for other things to fall in line, and then in time it'll be the right time. For someone who's been through the mill of testing and there's nothing else to be found and they're now sat in front of you, then I'd be saying, again, what's your thoughts? How did you feel when they said your scan was clear, your blood tests were all right? What's your thoughts about moving forwards now? You can be a bit more optimistic in those situations, because we can say we're happy, you're not going to break anything, you're not going to cause yourself any harm. I'd say there's space for there's a lot of space for optimism in that. We want them to be less fearful, right? Now, sometimes people will take that the wrong way and they will think, here, great, I'm not going to cause myself any problem. I will go for it. I'll go start running my 10Ks tomorrow, get back on the bike, blah, 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 blah. And then wonder why they've had a flare 3 days later. So there needs to be a bit of, I guess, safeguarding in that aspect, making sure they're not just going to go. But sometimes we look at these people with their fibromyalgia or whatever, and the tests are all fine, and we sometimes get a bit worried. But actually, I think, as you heard me say there, I think we can be optimistic because there's no restrictions. And sometimes for some people, that can really light a fire under them. That can be the bulb that says, actually, you know what? Okay, tests are fine. There may be some other factors involved, which you can discuss, depending on what you hear and what you want to discuss and what they know already. But actually, that can then set them up for this kind of positive spin on, if nothing needs to be done, let's get you working towards your values, what goals and what's important to you. What about you? What do you think?
I agree with where you're at. I think the difficulty is when the person's in the midst of a lot of mucking about, you would say, with pain and doing all these different things, where old me and ego-driven me would maybe get a little bit kind of abrasive towards those other folks who are, but I was one of those other folks too, where I was trying to manipulate it away or do some sort of MDT that was going to get it to go away. So I've had to pump the brakes. I understand when folks aren't there yet in their clinical journey to understand that maybe there's a time to like switch gears, and this isn't something that, even though it feels good for a day during the session, it's not giving them resulting changes in life. So I don't get as much confronting on the other practitioners. I just help people lead themselves through, like, how's it working? How's it lasting? And ideally at this earlier on in the discussion, I've gotten to what's meaningful, or maybe a few sessions, and I really get this values clarification that's been done to where I know what is meaningful to them, what matters to them. Because in a formal pain program where the person's been through it all and their docs are finally hopefully saying, there's not much more I can do for you, be it a pain physician or somebody where we need to get you in a pain program. And this is where we're going to try to help our physician colleagues around our pain program to recognize these patients, and that this isn't giving up. This is just giving them another option where we have a pain program that's going to give them a different approach that can hopefully give them some success. But in the midst of when they're in the merry-go-round, medical merry-go-round of trying all these different things, you have to be able to respect where they're at. Like you said, contextually, they're maybe not ready to make a different jump. But if you help them explore what they're doing, how's it working? Is it given, or are they moving closer to their values, which is this creative hopelessness exercise that's part of ACT's exercise that would be week 1 in our pain program. You help people, either in an individual or in a group, you help them walk through everything they've tried, what's worked, what's not, short-term benefits, short-term costs, long-term benefits, long-term costs. And then often with people, especially if they've spun through the system and they're not in the midst of the medical merry-go-round, they can see that there's maybe a bunch of things lining up in the short-term benefits, like felt good, felt great, might be some few things cost a lot in the short-term costs, different things. But a lot of times as you help guide people through the exercise, you'll see a column that fills with things that gave a lot of short-term gains. But then when they go to long-term benefits, there's just not much going on there. Like they're not closer or anywhere to it. And that can be a tough thing for folks to come to terms with. A lot of what we do is, hey, when you look at this patient or group, is this a matter that you're not trying hard enough? Can you look at that and say you haven't tried hard enough? And I don't think anybody can look at all these things you've been doing. And medicine's been pushing you to do all this. And I've often recommended a lot of these things for people. And we're still not where we want to be. Like what shows up when, and then I'll have folks like, when you look at this, what kind of showing up for you right now to see? And oftentimes some people get emotional, be it teary-eyed or angry, and this is real, this is a struggle. And that's where you hopefully open up an opportunity for them. Would you be willing to try something different? But in the midst of the person that's not there yet, they're still maybe packing their short-term benefits column full before they're ready to look that it isn't getting them the life they want. Then I just said, let's focus on getting you the life you want. And if it's still people that are spinning the wheels of, nope, this needs to get fixed. And I've had to have some of those conversations. Maybe I'm not the person for you right now. And you leave that open invitation for somebody that if it gets to a point where you feel like you've tried these things and you're still not getting to the life you want, then I'm going to be here for you. And we'll start this thing. We'll get you moving maybe in a different approach. How do you deal with that too, where folks are still, no, I want to be fixed. No, I want to be fixed. No, I want to be fixed.
I think we have a mutual friend in Jerry Durham, and he said something to me once, which I completely agree with, in that things often go wrong when expectations aren't asked, because you can clarify expectations, and then you can either say you can try and beat them or not. And if you say you can't be able to meet their expectations, or actually what you're able to achieve is maybe not in line with what's going to be possible, that's much better than a false hope and then wasting everyone's time in a way. Obviously, if you can meet the expectations, great, go for it. But setting the expectations early on, first time you meet them, at some point during probably at the end, towards the end of your first session. And then in this case, we've got someone who's still looking for a fix, and you're telling them that it looks like you've been through all these tests, been through all these things here, had surgery, injections, what have you. And what I've often asked them, actually, this may be helpful for some people, what have you been told by the other people you've seen? Now, what did they say? Because my boss has a great phrase, which is, sometimes people are told, but they don't hear. And they may not have. Now, the reason they don't hear may be because they didn't actually hear it, which is rare, or they chose not to hear. And that, in a way, if you can clarify from them what they've been told, they may have been told, nothing else we can do. This is going to be long term, but there isn't a fix. They may have been told that already. And then we get back to your great point and questions about, so what are your thoughts on that? What was going through your mind when they told you this? How have you been feeling? What have you been wanting to do about this since? And if they're still wanting to find the third, fourth opinion to see if they get a different way that can fix it, let them go for it. as you rightly said earlier, if it's the right time, great. If it's not, that's okay too. What you don't want to do is set a false expectation that then doesn't come to light and everyone's frustrated, not just them, but you, the service, etc. That's okay. Sometimes we have that in all other aspects of life as well. You may have a problem with your, I don't know, let's say electricity, which you think is a minor problem, but then actually the electrician comes down and says, oh no, sorry, that's going to need a lot more than what you thought. You may get another opinion that says the same thing, or someone's totally different. We have this in all aspects of life. It's no different in healthcare. Obviously it's affecting, in this case it's pain. But if you ask clarifying expectations early and finding out what they've been told and where they're at with it, and see where they want to go, and then this is a more closed question, but is this the right time to try and manage your pain, or you still want to try and find the fix? And we've both seen plenty, not, I'd say it's less than it used to be, but there's still people who just, it's not quite the right time. And they can, even if you've done nothing and just assessed them and clarified it's not the right time, if you've built some rapport, a good, decent relationship, when it is the right time, they'll hopefully come back to you. How do you manage it when they come in?
No, that's exactly pretty much how I would go about it, for sure, as far as help them unpack where they're at. Some people, are in the midst of still trying to fix, and you have an open discussion and have them kind of explore what they've been doing, how's it working, and you can just see that it's not working. And I've had people point blank say that, and I'm saying we see a lot of patients where they've been trying all the things, and I can hear your experience that you've been busting your tail to get this thing to improve. And unfortunately, it sounds like it hasn't gotten where you want it to. And we have a program that kind of helps folks in your situation maybe take a different approach that we found can give you some significant benefits in life. Would you be willing to try a different approach that maybe works on that? And then introduce some of the things that, like our pain program, or maybe it's a cognitive functional therapy type program, or whatever it may be. There's plenty of things out there, but one that prioritizes no longer sitting on the sideline until pain's fixed. This is get off the sidelines into life and learn how to keep pain. We respond to pain at a way that keeps us on task with our values and the person we want to live by, versus, again, I have a patient right now. She's talks about how she's like a full-time patient. Like her weeks are pretty much planned around medical appointments. She doesn't have any time because for her to get out of the house and to get prepared and to get ready, that's a massive undertaking for her. She's making some big changes just because she's been given permission to not seek to fix, and it's almost liberating for her, right? We've talked the drop the struggle analogy, and there's been the struggling in quicksand analogy and things we've used where sometimes the struggle is the problem, and it's this constant tussle with symptoms. And there's some nice ways you can kind of structure some conversations to have people explore that. There's exercises and ACT and various other things where people can explore that. But what do you think are the kind of skills or resources out there, or how would you recommend? Obviously, selfishly, we would love to have folks, because my thing is we need to get people better able to have these conversations to help people. There's a lot of good people teaching at Joe Tata, ourselves, Peter O'Sullivan's group's doing some good stuff. There's many others. So what do you think, if a clinician wants to get better at these skills, there's not really a textbook. There is a textbook. There are texts that can help people in these type of communication skills. But where do you sit with textbooks and then just getting reps? And that you can only read so much before you just get in there. And I always say you got to suck to get good at something. What's your thoughts?
Yes. And the textbooks, I agree. The irony that and these are more medical ones, but the prominent medical communication skills textbook is, I'll be honest with you, Mark. So we were talking so much praise about Louis Gifford's book. I would say, and that's so easy to read. It is so hard to read some of the communication textbooks, given what's being discussed in those books. I think, yes, you're right. There's a combination of reps. Certainly, that's probably the biggest player in it. If we were to put, obviously, our excellent resources in this project we're putting together as well, put that to one side, I think we can also learn from other industries as well. Things like marketing, sales, in a way. not that we're trying to sell per se, and I realize that word makes people sound a bit feel uncomfortable at times. But if you were to go to a car dealership and try and buy a car these days, they'd be asking you a lot of open questions as well. Things like, what do you do for a job? How often do you need to drive it? How many miles do you need to do a year? What kind of pack? They're doing a similar thing like we're doing to end up with a situation where hopefully we get into a point where the customer is choosing, selecting they're guiding the discovery towards whatever car it is. So I think there's a lot we can also learn from other industries. I don't have a specific salesman or marketing person. I'm going to say you must go and check out this person. But medicine has taken things from piloting, for example. There's things they've adopted that to increase safety standards. We can learn from these other areas, which in turn can make our practice better, I feel. I think that's where, especially with the future and how we're talking about, we're pretty good at, hopefully, getting better with the words. And as clinicians, we're trained to be logical and use science and data. But we have to remember that not the rest of the world is like that. And just throwing facts at people and saying, Marjorie, your disc degeneration here, if you're in your 70s, we can see that 70% of people in your age will also have disc degeneration or more, and they don't know about it. Marjorie may not care about that. Okay, that may be nothing to her. But what may be important, as you rightly said, and we've both said actually, is about what's important to you. What do you want to get back to? For Marjorie, it may be playing with her grandchildren. She couldn't care about her MRI report. But being able to look after her grandchildren while her daughter goes to work could be life-altering for many people. What do you think?
Absolutely. I would agree on the marketing sales. That's something I dug into deeply for the last, I think I mentioned on a few podcasts recently, where mainly to help clinicians recognize that they got a problem that traditional education and the learning more manipulations and more ways to put in something isn't going to solve this issue. They need to have a framework. And that's kind of what spurred on development of this. Well, and one, I guess, backing it up, I do think we owe it to our patients to have some skills to sell. And I'm okay saying sell, trying to take people and see how much I can empty their wallet, something to show that we have a valuable solution to what they're dealing with. If we have something that there's legitimate science behind, there's legitimate, obviously anecdotal, we got patients that can serve as social proof that our work, especially with people in their shoes. Why wouldn't we learn the skills to be able to confidently help guide a patient to make a decision? I don't think it has to be high pressure sales. We've all probably been in those, but saying, let me hear about your problem. What do you make of that? All the things, let them really put it all on the table and different things. And you say, here's what we can offer. It's a different approach type thing. And I just think there's so much to be said to just develop skills, and not persuasion in a non-ethical way, but persuasion to persuade them off of just to even look the fix approach, and that there might be something else. Even if you can open up the window for them to consider, that might give you another session to try and move them forward with something, I think is worth learning those skills. Yeah. And as far as how we teach it, I think our focus is on, and I think we've all learned things good this way, give people a scaffolding, like a framework. When we're building a house, something like we're building this persistent pain, psychologically informed, well-rounded pain clinician house, you need a framework or a scaffold to go around it so you can have something to give it some structural support as you're building this thing. That's how we would look at this program, is giving people an 8-week, it'll be a relatively defined framework and different things that people can kind of lead patients through. Of course, those who are out there are very experienced. You might be able to go off script and off playbook, because we've all learned things where it might have been a framework and we've probably all learned, like you mentioned in uni, the questions we should ask, and it was very scripted, and we might even had them written out and asked them in a specific order as we learned them. But then eventually we went off script and we went in whatever order fit the situation in front of us. So that's how we would look to help people with this type of thing, is give them a structured way to help people get through this. And then you'll be able to take that and then learn skills. And that's probably, and also the reason we're backing it up with a community, a mentorship community, because that's one thing to learn this and then just go on your own and try it. This is why learn it, try it, come back to your peer group, come back to your group mentoring sessions, and let's go through what's going well, what's not going well, and how do we help you kind of navigate that. Because that's one thing even when I was in fellowship, I mean, there was a little bit of some online discussions and things like that in some meetings, but a lot of that was not where it was this like peer learning, group learning, social learning activity where we're trying to help each other. Because I think it's also reassuring to see that the struggles you're having are struggles that many others have had. Ben and I, some of them we're still having. I don't think there's anything that says that this game is going to be something where it's ever easy. It's hard. Life's messy. Pain's hard. Pain's messy. It comes with a lot of difficult emotions, difficult sensations, difficult situations that some of our patients face. But man, I feel so much more comfortable and confident to navigate those uncertain situations, that I have some sort of framework to go off of. And community, like, part of the reason I do this podcast is it's like a support group for myself to talk to other clinicians and researchers who support me in my kind of questions of what I see in the clinic, and I can pose them to researchers and other clinicians who are dealing with the same things. So any thoughts you have to leave folks with today here, Ben?
Tell you what, I was thinking about earlier, we said about from the explaining side of things, but we've both been explaining pain less than we used to, finding out what people know, what do they want to know. I think we should also be clear that the last thing I've recently added to this is now a 3. What do they know? What do they want to know? What do they need to know? Someone may not want to know much. They may just want to move forward, but they may need to know about certain strategies, whether it's mindfulness, whether it's pacing, whether it's certain type of exercise, whatever it is, to help them then get to that, where we that discovery, and help them get to where we're both aiming for. So you can make your values, you can set your goals, you can build all the great relationship and trust. And most of the time, what they know is enough, but occasionally, I don't want people to take away here that we should never explain anything ever again, because sometimes it is appropriate and it will help that person. And I really like to point at that you said about sometimes it's data and sometimes it's anecdotes, because for some people, the anecdotes is what will help guide, not the data. We need to be, I mean, we'll talk about this more another time, but there is room for both. I know as clinicians, we're wired and trained to think about the logic and the RCTs and the systematic reviews and blah, 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 blah. But not everyone thinks that way. And sometimes an anecdote or a story is more appropriate. I think that's a good cliffhanger to leave people on before the next time.
Yeah, we'll expand on these topics as we go, and we're going to have a little bit of a topic series just to help folks kind of see just help, because I think we're trying to position these episodes as things we would have liked to hear other clinicians talk about when we were coming up and growing into our current situation as clinicians. And we're still growing, as we said. I'm 21 years in. Ben's not quite that far along, but we're still navigating difficult situations and learning how to better interact with people, and trying to create a community of folks that are on the same boat. And we're fortunate to have folks that listen to the podcast. I know, Ben, you got folks that listen to yours that are on the same journey with us. So we appreciate you all for joining us on the journey. If you have any questions, don't hesitate to reach out to either of us. We'll have contacts in the show notes. You also will put links to the books that Ben had mentioned earlier, the Gifford books, and the other book we mentioned earlier on. And for those of you who are interested in possibly being involved in our pain program, we're going to have it launching here, like I said, within a few months, to really give you guys the framework and all that stuff. There'll be a little bit of a interest list sign up in the comments as well if you want to get notified when that's going to go off and all that good stuff. So we'll leave it there this week. We'll talk to you all next week.